Let's say a hospital has become a victim of a ransomware attack, systems have been compromised, operations have been affected. This has happened. I'm not sure if you have had any first-hand experience with such a scenario. If you have, then of course, share with us what happens, what goes on, how is the hospital trying to deal with it or recover from it. And if you haven't had first-hand experience, share with us what are the do's and don'ts under these circumstances.
Okay, so I'm a little bit hesitant to speak about specific situations. I'll
Sure.
speak more generally in terms of what goes on or maybe some classic scenarios of what tends to happen. So when the systems go down, the digital systems, the networks, the first thing that providers notice is quiet. Physicians practice an environment of a lot of whistles and bells. So there's information coming in on the electronic health record, there's phones ringing, there's all sorts of processes that happen. Now, there's primary processes, meaning the EHR is not making noise, but as a consequence of that, there's downstream noises that may not be happening either. So the first thing one notices is what is quiet. And the quiet is sometimes reassuring for a moment. Oh, things are going well. There's no noise here. But it's a different kind of quiet, because in the conventional thought is no news is good news. When information systems are down, no news could be anything. So clinicians learn very quickly to transition from an information push environment to an information pull environment. So information push is when somebody needs something, when something's going wrong, information comes to the physician because there's so many good people working behind the scenes, whether it's pharmacy, whether it's the nursing team, whether it's the patient or family member alerting to all these things. So that's an information push environment, which is helpful. Now that it's gone quiet, it's become an information pull environment where clinicians often feel that they have to go out there and find that information. And where do they get that information? Usually it's from humans, because digging through the chart is not going to happen as well because systems are down, unreliable, degraded. And especially during ransomware attacks, sometimes systems need to be shut down deliberately. So you'll have, for example, computer units shut down. You'll have systems getting shut down. We don't know what's shut down. We don't know what's reliable or not. So we get into the information pull environment. And when we do that, we tend to rely more on humans.
Welcome to the Cybersecurity Readiness Podcast Series with Dr. Dave Chatterjee. Dr. Chatterjee is the author of the book Cybersecurity Readiness, a holistic and high-performance approach, a Sage publication. He has been studying cybersecurity for over a decade, authored and edited scholarly papers, delivered talks, conducted webinars and workshops, consulted with companies, and served on a cybersecurity SWAT team with chief information security officers. His work on proactive cybersecurity has been featured on USA Today. Dr. Chatterjee has been a tenured professor at the Terry College of Business at the University of Georgia. As a Duke University visiting scholar, Dr. Chatterjee teaches in the cybersecurity programs at the Pratt School of Engineering.
Hello, everyone. Welcome to the Cybersecurity Readiness Podcast Series. I'm your host, Dave Chatterjee. To set the stage for today's very interesting episode, consider this scenario. A nurse cannot confirm whether a cardiac patient's anticoagulant was administered overnight. The EHR, electronic health record, is degraded. The overnight nurse has left. There is no paper backup. She administers the dose. So did the overnight nurse. The patient receives a double dose. And this is not hypothetical. Variants have occurred during actual ransomware attacks and extended downtime events. Yet, most healthcare organizations, if not most, many, have not practiced for it, have not mapped which clinical dependencies fail first, and have not pre-assigned who makes what decisions when systems cannot be trusted. My guest today, Dr. Mark Yoffe, will enlighten us on this very important subject. Mark has a very interesting background. He's, of course, an MD, plus he is a cybersecurity professional. And that got my attention when we were having our preliminary meeting. And I asked Mark, I said, Mark, why did you do both? Why security and healthcare? And he says, why not? So let me turn it over to Mark. Mark, it's truly an honor to have you on the podcast. Share with the listeners some highlights of your professional journey and what brings you to where you are today.
Dr. Chatterjee, thank you very much for having me on this podcast. I'm an internal medicine physician, trained and board certified in internal medicine. Been practicing for a number of years. Along the way, I realized how much medicine depends on information, particularly digital information. And I became interested in it from the security standpoint. And the reason for that is I realized quite early that the words that we use in clinical medicine overlap sometimes quite strongly with some of the words that we use in information security. Namely, confidentiality is a word that's used both in cybersecurity and clinical medicine. Integrity, of course, used in both settings, and availability. We have to be available for our patients, much like the electronic health record needs to be available for us. So that was one of the main issues that sparked my interest in trying to bridge both professions, both areas.
Interesting. I want to probe a little further. Did anything happen, any incident that motivated you to also get very good at or develop a very good understanding of security aspects of your profession?
Well, aside from the ebb and flow of ordinary day-to-day practice and things that happen along the way, I believe that COVID-19 was a major drive for me. And the reason for that is there was so much unreliable information out there. I'm talking about among the general population. And even when it came to the credible information that was based on validated trials, information was changing very, very quickly. And we had to make decisions and changes to our decisions based on rapidly changing information. And in other words, we needed to make sure that the information that we had clinical integrity and had availability. So that was one of the major driving forces behind both my realization of how important information security is, but also in terms of my desire to delve into it a bit more deeply.
Thank you very much. Thank you for that. So when I was introducing this episode, and I used an example of a potential overdose because of a degradation of the electronic health records, I'm sure there's a much better and a more telling example of what could be the consequences to patient safety, to patient care, if security is not handled well or if security falls apart. Can you give us a better example?
Well, one example could be vital signs. So when, let's say, the regular way of doing things is someone who's in charge of getting vital signs will go to the floor and take the temperature, take the blood pressure, and record it in the electronic health record. When the electronic systems are degraded or not working, it's possible for someone to take the vital signs. Something is abnormal, but because of the process that they have or lack of process that they have, they may end up writing it on a piece of paper. And the paper doesn't flag with a red marking that, hey, this is abnormal, so they may not notice it. That paper might either disappear, or even if it's there, when one looks at it, one might not see directly that there's something wrong there. So that would be an example, although not to diminish from the idea that sometimes giving anticoagulation at a double dose could be fairly risky as well. But that's an example that for me comes to mind.
Well, thank you for sharing. So, let's take another scenario. Let's say a hospital has become a victim of a ransomware attack. Systems have been compromised. Operations have been affected. This has happened. I'm not sure if you have had any first-hand experience with such a scenario. If you have, then of course, share with us what happens, what goes on, how is the hospital trying to deal with it or recover from it. And if you haven't had first-hand experience, Share with us what are the do's and don'ts under these circumstances.
Okay, so I'm a little bit hesitant to speak about specific situations. I'll
Sure.
speak more generally in terms of what goes on, or maybe some classic scenarios of what tends to happen. So when the systems go down, the digital systems, the networks, the first thing that providers notice is quiet. Physicians practice in an environment of a lot of whistles and bells. So there's information coming in on the electronic health record, there's phones ringing, there's all sorts of processes that happen. Now, there's primary processes, meaning the EHR is not making noise, but as a consequence of that, there's downstream noises that may not be happening either. So the first thing one notices is what is quiet. And the quiet is sometimes reassuring for a moment. Oh, things are going well, there's no noise here. But it's a different kind of quiet. Because in the conventional thought is no news is good news. When information systems are down, no news could be anything. So clinicians learn very quickly to transition from an information push environment to an information pull environment. So information push is when somebody needs something, when something's going wrong, information comes to the physician because there's so many good people working behind the scenes, whether it's pharmacy, whether it's the nursing team, whether it's the patient or family member alerting to all these things. So that's an information push environment, which is helpful. Now that it's gone quiet, it's become an information pull environment where clinicians often feel that they have to go out there and find that information. And where do they get that information? Usually it's from humans, because digging through the chart is not going to happen as well because systems are down, unreliable, degraded. And especially during ransomware attacks, sometimes systems need to be shut down deliberately. So you'll have, for example, computer units shut down, you'll have systems getting shut down. We don't know what's shut down. We don't know what's reliable or not. So we get into the information pull environment. And when we do that, we tend to rely more on humans.
Absolutely. Thank you for sharing. And from the perspective of a consumer of healthcare, also from the perspective of a patient. In fact, I had my open heart surgery last year on June 20th. I remember it vividly. I have a lot of respect for your profession, a lot of respect for the doctors, for the nurses, for all healthcare workers, because I've received tremendous care myself and truly grateful. So that enhances the significance of this episode, because I have often wondered that y'all are constantly having to make decisions. It's a very challenging environment to work in. And your diagnosis, your procedures, your actions are all based on the information that you're gathering from the different tests. And so I'm imagining a scenario when the systems go down and the information is not readily available. And you're dealing with a critical care case where you have to make decisions really quickly. You have to be prepared for it. I'm just curious to know, in other organizations, in non-healthcare organizations, they have tabletop exercises. I would like to believe many organizations try to rehearse some of their disaster recovery practices or action items, action plans. What do you guys do? Do you all have such playbooks? How reliably to recover from, say, a ransomware attack? And are these plans and procedures rehearsed?
Yeah, so again, I'm going to stay away from speaking to specific institutions,
Right.
but I could say there are almost always playbooks, almost always rehearsals that deal with what do we do when certain information is not available. I will point out also that clinically, there's almost always an information deficit. People coming in, whether they're in the hospital, in the emergency department, something happens and decisions need to be made rapidly. Very commonly, there's not enough information. So it's not as though clinicians are not able to practice with less than complete information. It's just a question of gradation, how much information is lacking. And hopefully, the more training we have, the better we're able to recognize who's sick and who needs a decision now. And interestingly, when patients are not doing well and very sick, sometimes the decisions that need to be made are much narrower than they would be if in a well patient. So for example, does the patient need a breathing tube? Do they need to be intubated now? Do they need blood pressure medication? Do they need fluids? Those decisions oftentimes don't need a lot of information compared to when we're stepping back and it's a complex picture. We need to make a decision. It's a little bit more long range. So the decision-making process sometimes is actually okay or easier. I wouldn't say easier, but more okay when there's fewer decisions that need to be made.
So am I correct in inferring that even if the systems were to go down, it doesn't imply that the hospital is totally paralyzed or impaired, because you all rely on a lot of experience and you have people to talk to make calls. So all is not lost or all hell hasn't broken loose when situations such as I mentioned, when systems go down, when that happens. Is that correct?
That is correct. Yes, there are always almost always compensatory mechanisms,
right.
And my view is that the most important compensatory mechanism is really a throwback to the way medicine was back in the day. Written charts at the bedside, physical examination. So when these things happen where the digital is not working, we again, like I said, we revert back to the human side, or I'd say maybe place more emphasis on the human side.
Awesome. Now let me step back and reflect on the big picture. You decided to come on my episode. I think this is the first time I have a guest who is both a trained doctor as well as a cybersecurity expertise. Now, you don't practice as a cybersecurity personnel, correct?
Yeah.
So you do? You said?
So at the moment, I'm going to speak generally to what goes on. Yeah.
Fair enough. So I guess my question is, what brings you to this podcast? What is it that you want to share with the listeners? And if there is any particular types of listeners, like I was sharing during our planning meeting, I have a wide spectrum of listeners, got C-level executives, frontline security personnel, academics, doctoral students. So fairly a broad section. So what do you want to get across by way of key messages here?
I think firstly, to the cybersecurity people who specialize in cybersecurity and nothing more, I think sometimes there might be a temptation to think, what am I doing here? I'm sitting in front of a computer screen. I'm keeping the networks humming. It's just another day at the job. Again, I haven't done that from that perspective, but I think when we sit behind a computer and we're doing things with our fingers, sometimes that's tempting to think that way. And maybe we're not thinking enough of what's happening on the other side of things. When we keep the systems humming along, we're taking care of patients. Yeah. When we're keeping the network secure, we are implementing confidentiality. When we're keeping the information available, we're keeping patient care available. So all these items that people are doing behind the screen translate into extremely important and highly leveraged real world consequences. And I think it's very important to keep in mind, both from a day-to-day job and also in terms of the ability to speak with leadership about what's needed. So as an example would be, if let's say I believe that my system as a cybersecurity professional, not as a physician, suppose I'm a cybersecurity person only, and I believe that my uptime should be 99% because that's the industry standard, for example. So I might make the case to the leadership and say, it's supposed to be 99, we're 98.5. Well, that's a cybersecurity criterion. That's an IT criterion. Mm-hmm. Have you communicated that in a language that the leader would understand? So what does a leader understand? Well, the leader understands the mission. The leader understands the patient care. The leader understands availability in terms of access to care, the ability to treat patients. So when we have this broader perspective of the way what we're doing helps the organization, it empowers us to communicate with leadership. And the task of leadership, which I'm sure the leaders are there for a reason, is they are able to translate these different languages into a coherent execution and exercise of the mission of the organization.
Very true. In fact, as you were sharing some of the important messages, What comes to mind is my CPD framework, commitment,
Yes.
preparedness, and discipline framework. In fact, my research in cybersecurity centers on that framework. It is designed to help organizations deal with high stress security situations and be very proactive about it. To delve a little deeper into the framework and connect it to the discussion context today, when we're talking about commitment, we're talking about the resolve of the leadership to make cybersecurity a strategic organizational priority, not merely a compliance checkbox. And this is not a hard sell when it comes to healthcare organizations, because when I'm talking to the leadership, I tell them that, look, if you are not actively committed to cybersecurity governance, cybersecurity best practices, patient care will be affected. Patients could die. So the consequences are drastic. We are not talking about, say, a retailer or a wholesaler of, say, garments. There are consequences that can be pretty bad. So I'm not trying to dilute the consequences in any industry, but healthcare does have very catastrophic consequences if security is not done right. And so from a commitment standpoint, that message has to be clearly, or the leadership is not getting it. Whoever is trying to communicate with the leadership, the security needs of the organization, the communication has to go beyond the technical. The communication has to be in the language that the leadership, the doctors understand. I'm sure the president of a hospital is an MD. So if you go to him or her and you talk about the security challenges, security implications, and you get very technical about it, they may or may not understand. But if you connect it to patient care, to patient safety, you are likely to get their attention right away. So that's commitment at a high level. Then when we talk about preparedness, we talk about the depth and rigor of an organization's defenses. We're talking about the people, the processes, and technologies that are being marshaled to detect, to respond, and to recover from the different types of threats and attacks. And finally, the discipline anchor or the discipline pillar of the CPD framework is all about consistent day-to-day execution of superior security practices, whether we are talking about patch management, access controls, security awareness training, penetration testing, real-time audits, name it, continuous monitoring. Are they being done well? Are they being done continuously? Are the findings being properly recorded? Are the findings being promptly reviewed? And are actions being taken in a timely manner? That's the discipline aspect. It's easier said than done. Large organizations, hospitals, trying to take care of patients, that's a huge, huge undertaking. So it is quite possible that the leadership might think that, okay, we have a security team and it's their job to do this well, so we could focus on patient care. And that's a very fair and compelling argument. However, it is my conviction that even the medical professionals, the healthcare workers, need to have some familiarity with the security implications of their job. So they also do their part within the scope of their work to help the organization be a little more secure. That's why I found that you were quite the unique case where you are not only a trained doctor, a physician, an internist, but your level of security awareness is way higher than the others. So that places you in a highly unique position to further the cause, to champion the significance of security. And that intrigued me, and that's why I was motivated to get you on the podcast and have you talking. Yes, we're talking in the context of healthcare, but it will be amazing, and it will surely be a best practice if even organizations in other sectors encouraged people to raise their awareness and knowledge on regarding cybersecurity. Not that any and everybody can complete a CISSP and others. These are challenging certifications. I'm not doubting anybody's ability to do that. It's a matter of making the time, the effort, the interest. But for those who can, I think it can only help and not hurt from the bigger scheme of things. Anyhow, I'm going to pause and turn it back to you, Mark. Any thoughts, reactions?
Yes. So I believe that in stress situations, we fall to the level of our instincts.
Yeah.
And an analogy I would give is, let's say, someone who's trained in martial arts, and whether it's jujitsu or karate, and they've done the katas, which is the ritualized almost movements. When it comes to the real fight, they're not going to remember the kata or the formalized movements. They're going to fall to the level of their instincts, which is what have they done in similar scenarios over and over and over and over again. So that's the discipline that you mentioned in your framework. If somebody at home is using their bank password the same as what they've used for Disney Plus, we kind of know what their, let's just say, personal cybersecurity posture is going to look like. And we don't have to say. So if someone has a cybersecurity awareness generally, good cybersecurity hygiene, good practices as it relates to being aware of how valuable stolen data is, for example. When something does happen, they're in a much, much better position to do things carefully and the right way. So yes, tabletop exercises and all those things are very important, but what's also very important is what happens on the retail level, which is the discipline that you've mentioned. And the other thing goes back to the communication. We talk about, well, the leadership is up here and they're doing this, and I'm here and I'm doing that. But what are we really speaking about? We're speaking about a bridge, and how do we bridge the communication gap? So sometimes instead of saying, well, the leadership doesn't get it, we need to ask, what can I do to communicate better with them? So in other words, in that sense, we are an extension of a part of the organization, and we are an extension of leadership in a way, because we are implementing the mission by two-way communication, not just them handing down what the verdict is going to be in terms of budget, but also what are we doing to elevate situations that need more attention.
True. And you mentioned this earlier. I'm going to paraphrase it. If you want to get buy-in from organizational members across levels, you have to be able to show them the big picture. Like, yes, you're staring at a screen, trying to monitor traffic. It can be a boring and laborious job. But if you let them know that the indirect impact of their monitoring is helping the organization perform, provide care in the best possible manner, or reduce the probability of attacks, which has these kinds of consequences. So in other words, their job that they're doing has impact, even if the impact is indirect. That's actually huge. And I say this from a first-hand experience. When I started my corporate career, I joined a very large organization, and I was placed in internal audit because that's how that organization liked to get their new people trained or become familiar with the different aspects of their operations. While I enjoyed my job, while I enjoyed the setting, I enjoyed the people, I would often wonder that if I didn't show up for work, would anybody notice? Or did it really matter what I did? I was very early in my career, but still it was important to me that the hours I'm spending reviewing ledgers and reviewing files folders, reviewing system records, did that have an impact on the top line or the bottom line? And it comes back to what you just talked about, communication effectiveness. It's very critical that communication be done at a level in a manner that is relatable. You cannot communicate the same way to a technical person as you would communicate to a non-technical person, or to a senior level executive as you would to a junior level executive. So communication has to be very customized, has to be personalized, has to have goals, and there has to be a feedback mechanism to ensure that what you're trying to communicate has actually been received the same way. So communication is extremely, extremely critical. And it's a huge part of security governance. Moving along to another topic which is related to security governance is AI governance. Healthcare organizations are adopting AI-assisted clinical decision support. All kinds of tools, AI-enabled tools, are being adopted. What is your perspective of AI governance in healthcare?
I believe that AI governance is a very difficult topic, and even speaking about AI governance is difficult, and for a number of reasons. I think number one is AI is not a tool in the same way that a scalpel is a tool. Or a hammer is a tool. You take a hammer, you put it in the drawer, and you go the next day, you take the hammer out. It's the same hammer as it was yesterday. AI doesn't work that way, of course. AI is constantly learning second to second, minute to minute, day to day. So the tool we use today, almost by its very nature, cannot be governed in exactly the same way as the tool of yesterday. So if we're approving a scalpel, for example, you get approval for the device, and whatever committees need to approve it, whatever needs to be done on the federal level, that's approved. You know that this particular device with these particular engineering parameters is approved once and for all. AI is completely different. So what are we even talking about when we have a policy to govern tool X? Because tool X today is going to be tool Y tomorrow. So that's one of the first thing that comes to mind. The other thing that makes AI different is that in some way it's a smarter thing than us. And when in the history of the world have we even talked about governing tools that are smarter than us? Is it even possible for a 9-year-old to govern a 43-year-old? So those are, I think, conceptually, those are two of the main challenges of even speaking about AI governance. Nonetheless, we got to do the best we can with the language that we have and with the understanding that we have. So there has to be some policies in place to help that, although we have to understand that this is a completely different scenario compared to ways we were talking about governance and controls, basically for as long as governance and controls have been around.
Yeah, absolutely. And recently I was talking to a friend who's in the medical profession, and he mentioned that there's a growing use of AI-enabled X-ray machines for conducting X-rays or for reading X-rays. Pardon me if I'm a little off track here, but the whole idea is because of the volume of X-rays that have to be read, use of AI tools to read the X-rays is understandable. Then as a patient, my question is, but did a physician or whoever, the doctor concerned, did they review the report generated by the AI tool? And of course, the answer was yes. There is a human, an expert who would definitely still review. But that's where governance comes in, because governance is all about, yes, you want to automate operations in an intelligent manner, which is where AI comes in. But there also has to be checks and balances to make sure that the outcome is not degraded, is not flawed, and is consistently of high value, especially when we are talking about medical care. So that's the diagnostic side. Now, if you look at surgery, every day or every other day, I come across some articles, some ad about, here they have come up with a procedure which is robotics enabled, which is AI enabled. And it's fantastic news to somebody as a layperson. I'm not a medical professional, but I would like to hear less intervention, less intrusion so the recovery can be faster for somebody who had an open heart bypass surgery. It is always a welcome news if I get to hear that these open heart surgeries may not need to be done, or it can be handled with less intrusive AI-enabled methods. So anyhow, but then again, when surgeons are relying on AI tools, and AI is influenced by the information that is being processed, by how they are being calibrated, how the decision logic works, and that is constantly changing, and that can be manipulated through attacks, through different types of attacks. That makes governance, as you said, all the more difficult, all the more challenging. I'm not sure if this is an area that you're comfortable talking about, but as a medic, I'd still like to get your thoughts.
Sure. So I think that goes back again to this notion that in some ways AI is smarter than us. And governance is really what we're talking about is oversight and ownership. So oversight is who is overseeing who from the governance level, the leadership over the people who implement the controls and so forth. So we're talking about oversight, who's overseeing what. And the classical way is, as you mentioned, the physician should oversee the results of the AI. But what about the other way around? I mean, if AI is so smart, maybe it should be overseeing us. So at least to some degree, right?
That's right. That's right.
So it's entirely possible to conceive of this as a bidirectional oversight almost. And maybe it's more than almost, maybe it's actually here. So bidirectional oversight may be already in play. But ultimately, I think the core issue is professional ownership. So AI is not going to own the decision.
Correct.
Never going to own the decision. It's always going to be the professional who owns the decision. And what we mean by professional ownership, as distinguished from ordinary ownership or business ownership, is, let's say I'm the head of internal auditing, for example, and I need a spreadsheet. So from an organizational standpoint, the organization really doesn't care whether I assign the spreadsheet activity to Bob from accounting or Bill from housekeeping, because they know this person owns the process. And if they do not do it correctly, then they have to answer to the process. But again, fundamentally, the organization shouldn't care all that much sure, they don't want you outsourcing it to a foreign country, but the concept nonetheless is there, is how you get the work done is less important when you're not talking about a licensed professional compared to when you're talking about a licensed professional. A licensed professional cannot delegate their ownership. So if I'm not a surgeon, but if I were to do surgery, and I'm talking about outside the context of a residency or trainee, I cannot bring in, let's say, the salesperson of the device to do the surgery and call it my own. So in that sense, what we're looking for is professional ownership. And as far as the ability to oversight, again, maybe we're talking about a model that's bidirectional, but certainly professional ownership is a unidirectional concept.
Exactly. And when you talk about ownership, I go back to my framework where under the commitment umbrella comes assigning of ownership and responsibility, along with empowering people with the necessary resources, decision-making capabilities, so they can do a good job owning the different tasks, different roles. I'm not a medical professional, but I'm just going to use my common sense and say that, let's say a patient has been admitted, a doctor has been assigned to the patient. Depending on the complexity of the case, there'll probably be a team of doctors discussing the patient and what needs to be done with the patient. I'm assuming that there's going to be some decision-making authority, some accountability, some responsibility, some ownership right there, because they will be using different types of tools, physical, electronic, to provide the care. But at the end of the day, the ownership, as far as patient safety goes, quality of patient care goes, still rests on either one individual or a team. And that speaks to what you said, that governance is really about having total clarity on how ownership, how accountability is going to be handled, who owns it, what resources they have, and what is going to be the nature of the relationship between the resources and the humans. You cannot blame a technology if a procedure fails. The blame will still have to be taken by the individual. The technology can provide the support, can provide the help. So there has to be total clarity of expectations. And then the execution also needs to be monitored, reviewed. And I've heard from my surgeon friends that when they are doing surgery. The surgery gets recorded for reviews and other purposes. So I'm sure there are lots of checks and balances in place, oversights in place, both human and electronic, to make sure that the quality of care that is being delivered is of the highest order. So the challenging aspect is the more technology that we use, the more data that we have to deal with. There are more vulnerabilities. There are more opportunities for undesirable exposure, for exploitation of those gaps, of those loopholes. So despite the many benefits of electronic health records, of sophisticated tools, there are too many downsides. The question is not that we can go back to the old ways. We have to continue to move forward with the aid of technology, but we have to be very cautious. We have to be very deliberate. We have to plan. And that's where, once again, governance comes into play. So governance cannot be ignored. Governance has to be an important part of patient safety. So there has to be clear depiction of how, through robust governance, patient safety can be enhanced. When that relationship is clearly depicted graphically through documents and people understand it, people have a good understanding, that makes it a lot easier when it comes to implementation, when it comes to sustenance. So that's kind of the way governance is handled across the board if it's done well. Mark, any thoughts, reactions?
Yes, I agree. Governance really sets the stage and sets the direction entirely, almost, in terms of what needs to happen for an organization to fulfill its mission. If people are going each in a different direction, they may be correct on a narrow issue, but they may not be executing what needs to be done from an organization, from a leadership, from a governance standpoint. So governance is what leads to controls, and controls leads to activities that are consistent with the mission of the organization more generally. So I agree fully that governance is absolutely central to any kind of technology, but certainly with AI, it's extremely important.
Exactly. Going back to the framework, commitment, preparedness, and discipline, when commitment is shallow, preparedness investments are perpetually deferred, and discipline degrades because there is no clear or senior signal that the practices matter. So these three pillars of governance are intimately, intrinsically connected, related, and they all have to be done well. I use the theory of strategic alignment. Whether it's cybersecurity strategy, whether it's healthcare strategy, whether it's any other strategy, they all have to be integrated for the organization to deliver effectively. You can't treat them in a siloed manner. You can't just palm them off or outsource them and say, okay, cybersecurity is your business, and if something goes wrong, we will hold you responsible. From a delegation standpoint, that is understandable, but at the end of the day, if the quality of care suffers, everybody will be affected. I mean, all the personnel, the hospital's reputation will be affected. So one has to look at cybersecurity governance, AI governance in a very integrated manner and align it with the overall goals of the organization, whether it's healthcare or any other industry. Well, good things unfortunately come to an end. So this discussion, as much as I've enjoyed it, we have to call it for today. But I always like my guests to have the final word. So Mark, any final thoughts?
Yeah, thank you, Dr. Chatterjee, for having me. It was really a joy and a pleasure to participate in this discussion. If I could reiterate a point or so, I would say, again, preparation is key, and the discipline, the habits that we form in our daily lives, but also in a company life, what we do within our daily jobs are what prepares us to act in situations where systems are degraded or things are compromised. So I think it's not just something that we say, oh, let's take care of it when we do the tabletop, but let's prepare ourselves in our day-to-day activities to have commitment, the preparedness, and the discipline to actually get this done in terms of cybersecurity.
Well, Mark, it's truly been a pleasure. I hope to do another episode with you in the near future.
Okay, we'll discuss.
Thank you, Mark.
Okay, thank you, Dr. Chatterjee.
The information contained in this podcast is for general guidance only. The discussants assume no responsibility or liability for any errors or omissions in the content of this podcast. The information contained in this podcast is provided on an as-is basis with no guarantee of completeness, accuracy, usefulness, or timeliness. The opinions and recommendations expressed in this podcast are those of the discussants and not of any organization.